السلام عليكم ورحمة الله وبركاته. بيسعدنا إن احنا نبدأ الجلسة العلمية الأولى، وطبعا شرف ليا كبير إن أنا أقدم الأستاذة الدكتورة سامية نصر. يعني حقيقي هي من الناس اللي لازم نفتخر بيها قوي، إن حد بيسيب مصر وبيشتغل بره وبعدين يبقى مصر دايما في باله. واحنا الصبحيه دكتور سامي واحنا بنتكلم، هو فعلا زي ما هي بتتكلم ده اللي بتعمله، ده حلم عمرها انها تعمل حاجه لبلدها. دكتوره ساميه استاذ طب الاطفال في ميشيغان، وهي الجهد اللي بتعمله في السيستيك فايبروز في مصر ده بالتاكيد هيتحسب لها كام كبير قوي، وحقيقي شيء كويس. ويا ريت نبدا نعرف بس الاحصائيات مبدئيا، والجهد بعد كده حضرتك مش هتسيبينا فيه برضه. يسعدني الدكتوره ساميه، اتفضلي حضرتك.
شكرا. اوكي، الدكتوره ايمان عامله دوشه كتير. لا انا ما قلتش حضرتك يا ايمان. alright. الف شكر ويشرفني ان انا معاكم هنا. ودون ريلي بدايه، انا ابتديت اشتغل في سيستيك فايبروسيس في مصر من 1997. اول لما جيت اول مره وابتديت اتكلم على سيستيك فايبروسيس and it wasn't really in anybody's radar. Everybody was saying it's just an interest. But yeah, you can talk about cystic fibrosis, but we don't have it in Egypt. But since then, things evolved. I remember doing a project with Maggie Naguib, my dear friend, about to just convince people that CF is here in Egypt. I know Dr. Karima did a lot of work, Dr. Rabah did a lot of work, Dr. Anisa did a lot of work, not Anisa, but other Ikram, Dr. Ikram did a lot of work as well. But it wasn't really in the front of our focus. So when we did the project and diagnosed cases in the GI and in the pulmonary clinic, kind of like the ball start rolling. So since then we've been having cystic fibrosis being diagnosed to a lesser extent, not to broadly in Egypt kind of thing. So I'm very lucky that I was able to convince the Middle East CF Association and the CF Foundation to donate equipment for Egypt. But that's really the start of the real work. The start of it's going to be a long project. And like I said before, it's my dream. And I'm very lucky that all the groups that I'm working with are very excited and willing to work with me. So I'll do anything need to be done, but we need the help from everybody. So I'm really excited about that. So the collaboration. So I'm going to be starting to talk about CF diagnosis and newborn screen, which I know is not in Egypt. I know there's some pilot projects going on that I've heard about, and I'll be very happy to help in any way that's needed if that's required. So So just a history about cystic fibrosis. So cystic fibrosis was first actually identified in the Middle Ages by physicians in the German countries. And in Germany, it was known as like, if you test your baby and the baby is salty, he's gonna die or she's gonna die before a year of age. But that was really the knowledge that was distributed at that time. But it wasn't until 1905 when an Austrian physician described Meconium ileus. Again, wasn't really done CF at the time, but it was just described. And the beginning of the journey of cystic fibrosis started in 1938. And at that time, Dorothy Anderson, who's a pathologist, was performing autopsies on babies that are dying young, described cystic fibrosis and actually gave it the name. And because she found a lot of cysts in the lungs, and then in the pancreas, there was a lot of fibrosis. So she called it cystic fibrosis. And since then, the name stuck. So we've been calling it cystic fibrosis since then. Then that was descriptive of what cystic fibrosis is. But in 1948, there was a heat wave in New York City, and patients were getting very dehydrated. And there was a lot of abnormalities of how the dehydration happened in some of the kids and how the degree of dehydration. And that's the basis for the sweat test, that they found that a lot of these kids are losing a lot of salts and then that getting more dehydrated than normal the other kids. So that started the thinking about the sweat testing. Then it wasn't until 1950s, late 50s, when the sweat testing was actually done as a test and distributed. So to diagnose cystic fibrosis, you have to have two of these, one of each. So it has to be the phenotypic characteristics of the disease or history in siblings. So if you have a sibling with cystic fibrosis, that could be considered one of these, or newborn screen positive, which we're doing in the US across the country. So I usually get cases, most of my new cases are coming through newborn screen. And you have to have a sweat test. Sweat test is the gold standard for diagnosing CF. So if you have a CF, if you have a phenotypic characteristic and 2 mutations, and that's it, that's not enough. You have to have a sweat test. It has to be a positive sweat test, or at least borderline sweat test, that depending on the mutation that you're having. So, but keep in mind that if you have a positive sweat test, that doesn't mean it's cystic fibrosis. There are other reasons for having a sweat test, positive sweat test. And these are the list of them. I'm not gonna read through them, but it's very important to see that there is malnutrition. You could have a positive newborn positive sweat test, but it's not CF. So after they are well nourished, so Dr. May can fix that and make them more well nourished, then you have to repeat the sweat again. And then the other one, eczema, we don't usually do sweat testing on kids with eczema because there is a lot of damage in the skin anyway. So we wait till it's more stable, then we do it. And of course, in Egypt, G6PD deficiency. In the US, when I say G6PD deficiency, okay, yeah, we don't have cases unless it's from the Middle East. Then you can have a false negative test. That's why it doesn't help if every university or every city in the country here have sweat testing equipment. You have to have it centralized. So having it in 5 or 6 centers around the country should be enough, because you have to do enough of them to be accurate. You have to have the technical people that are doing it. You have to be qualified or doing it regularly. You have to certify. So that's very important. So I think right now we have the 5 universities and Cairo University. You have 6 universities in Egypt, and that covers most of the country. I think that should be enough to get going, not to insist every university have their own equipment. So that's technical. Some medications might give you a false negative, so you have to remember that as well. And if the babies have peripheral edema, again, fix the nutrition, fix the edema, and then retest them again if you think it is CF. There are some factors that can affect the presentation of CF, and that could be cigarette smoking or vaping. I don't know if vaping is famous in Egypt or not. I think I've seen some cases, but that can affect the disease. Allergies can affect the disease, viral pathogens, pathogenic acquisition, the type and the timing. Like Dr. Iman was saying that she has babies with Pseudomonas aeruginosa, which is a bacteria that can deteriorate your lung function faster. And that is not a good sign. So you really have to work harder on these kids. And then also socioeconomic. So if I have patients coming in from lower socioeconomic class, most likely they'll be sicker because the care and the follow-up is not as good. There are some modifier genes. So we have, I have siblings. I have kids was coming in, 2 brothers, 2 sisters, or a mix coming in, and one of them would be a very, very severe disease, and the other one would be mild. And why is that? They are the same genetic mutations, and that because there are some of them might have an modifier genes regulating the CF gene. And some of them, there are some modifier genes like the alpha-1 antitrypsin, the anti-cholimitrypsin as well. And then there is a lot of research in this area in the US. So for now, we don't really need to worry about this, but knowing that if you have 2 siblings with cystic fibrosis, that doesn't mean they have the same picture of the disease. Genetic-wise, there's more than 2,000 mutations happened, and there are some specific that we were able to find in Egypt, and actually some were in general. So we have the Delta F508 is the most common mutation, and also is the most common in Egypt, as far as I know. The function of the CF gene, so it's really a very, very large gene. It's 10 times the length of any other gene or average genes. And what you can see is that it consists of two membrane binding domains that are sitting in the cell membrane surface. And then there's some of them that are part of it, the nucleotide binding domain 1 and 2, and the R domain are in the cytoplasm. And it actually consists of a chloride channel. So the two, there are 2 6 membrane. This is the 6 of them, and the other one from the other side, and it's causing like an influx of the chloride, or the sodium follows as well. So it's really a gene that is embedded in the cell surface. So in Egypt, there was some work done by the group in Prague, and looked at some mutations that we can look at. The participants, Dr. Mona participated in it, but what I'm presenting is not part of her mutations as per her request. But Dr. Iman, Dr. Nader, Dr. Osama, and Maggie as well participated in the sample that were sent there to Milan Masek in Prague. And what he found is that the most common is Delta F508. It is not as common as in the US, where it's more than 50% of my patients are Delta F508 homozygous, and up to 90% of them are heterozygous. Excuse me. But he was able to identify some mutations that are specific to Egypt, which is really the goal, is to do enough of them and then to create a panel for mutation analysis for the Egyptian population. So when you send it, so the labs can create a panel for you that you can just test against it. So, which is very important. So he was able to identify several mutations that are very specific to Egyptians. In here you can see Dr. Nader, the most common, with the CFTR deletion of 17A to 18, and then Delta F, and Delta F in all the others as well. So he was, and then Ain Shams showed that there was some other mutations as well. So switching gears to newborn screen. So the best way to diagnose CF really is at birth. It's a genetic disease, you know, they're born with it. So really doing it at birth is the way to go. So you can get them before they get sick. And that's why now I have in the US, a lot of my patient population are very healthy. And the median survival is improving tremendously now. We're seeing patients in the 80s and in the 70s with cystic fibrosis, and they're functional, doing fine. So, which is really important. So when I have a baby coming in, newborn screen, normal baby looking, and we're telling the patient that you have cystic fibrosis, that is a lot of anxiety creating to them. But at the same time, I tell them the good news is we're ahead of the game. We're early on, so we can help you keep the baby healthy. So in the US, all the states are doing it. We do immune reactive trypsinogen. And then in some states have a fixed number if you're above that number, you're positive. If you're below it, you're negative. Ours, we have a floating value. So ours is mainly a 96th percentile for the day. So if you have a lot of African American, which the IRT would be low, they wouldn't be disadvantaged by having a fixed number. So we're doing that quite a bit. And then we're doing either DNA analysis, and in Michigan, we're doing 60 mutation panels. Some states are doing repeat IRT, but right now, all the states that are doing repeat IRT, which is 1/3 of the country, going to switch to DNA analysis. And there is different protocols coming in right now. So why is the serum IRT? Why is it important to do immune reactive trypsinogen? So it's a pancreatic enzyme precursor elevated at birth in CF, but it could be elevated in other diseases as well. And pancreatic duct obstruction associated with more enzymes in the serum. And IRT does not indicate severity of disease. So if I have an IRT of 200, that doesn't mean it's going to be a severe patient compared to one that has 60. So it's important to keep that in mind. An IRT, and then also elevated in prematurity and in fetal hypoxia and sepsis as well. So we had we have about 120 births in Michigan, and about 5,000 of them would have high IRT. Then when we do the mutation analysis, we end up with about 350. So it's not everyone with high IRT will be ending up having sweat tests. So the factor that can affect IRT is age-related values. So when you're doing a newborn screen, it's going to be different than when you're doing 2 weeks old. And then IRT values may be lower with infant with meconium ileus because there is an obstruction in the intestine. So a lot of the time we get negative newborn screen with meconium ileus. So we have our surgeons aware of that. So if there is a meconium ileus, they always call us. And then we usually go talk to the parents because it's most likely CF most of the time. As ethnicity and seasonal variation may be affected as well. So IRT DNA approach has been very helpful to us, and we expanded from 40 mutations to 60, and I'm hoping to go into the next generation sequencing, which is sequencing the whole gene. Screening benefits are, a lot to me. So early intervention is important. You're focusing on nutrition because you get them later on without newborn screen with being failure to thrive. That's the most common. And also pneumonias might happen. So you're ahead of the game. You're watching them. When we diagnose them, we see them every month. At the beginning, we see them like in 2 weeks. So that way we can keep track of them. So when you see them every month, you're keeping track of the nutrition, the GI, the pulmonary status. And then also that way you're not being delayed. The babies are not delayed in development. And so that's very important. But the flip side of that, the anxiety of the parents. So you have to work. We have a social worker and psychologist with us. And that's been leading to improved survival. The risks, stress, for false positive, because you have 350 in my state that are positive with 1 or 2 mutations, then you only diagnose 35 of them. So there is quite a bit of like 1 in 9 going to be CF. So the other 8 going to be really stressed out parents. Borderline results can be a problem. Counseling for carriers is important. So we have a genetic counselor that work with us. And then early exposure to pathogen in the CF clinic. We are very focusing on infection control. I don't think in Egypt you're going to have infection control yet because everybody comes in together. But in the US, we have people masked and masked. And when they come to the clinic, we put them in rooms real quick and we don't have them congregate outside. Again, you just have to be careful with the family and you have to work with them. But the psychological impact is misdiagnosing is really important. So you have to remember again, sometimes I have a CF patient that would be, CRMS or cystic fibrosis related metabolic syndrome, which is the borderline group. And then that way you have to remember to work with your family. You have to really work with them to educate them. So this is my protocol in the US, in Egypt, and in Michigan, and I'm overseeing the newborn screen processes in the state. So this is our algorithm. I can share it with whoever is interested later on. I'm not going to go through it today for time-wise. And it's important to remember if it's 2 mutations, it's cystic fibrosis. If it's 1, then you really have to work through the protocol. These are the mutations that we test in the Michigan, and they looked at the milieu of the patients in Michigan and created this one for us. So the take-home message is no screening. It's a screening assay, so you might miss cases. So we usually tell people that. So no, you cannot sue me if you have a positive baby with CF later on because the newborn screen missed it, because it's a screening tool. And it's important to remember that the diagnosis of CF is based on clinical presentation and confirmed by the labs, and that the CF diagnosis based on symptoms and is associated with delayed in the diagnosis that would be more detrimental to the outcome for these patients. And then the CDC and the CF Foundation endorsed the universal newborn screener, but it took years. We started in 1980 with the newborn screen as a pilot in Colorado, and then followed by Wisconsin. And then it took from 1980 to 2007 when we started to do newborn screen globally in the US. The median survival is improving, but we still have ways to go. So even though our median survival now is about 47 years of age, but look at the normal population in the US, and that's what we're aiming for. We're aiming for a straight line up, if that can be. And the modulators have been unbelievably effective in treating that. And this is my university, and thank you very much.
بسم الله الرحمن الرحيم. دكتورة سامية، الحقيقة يعني بعد كل اللي اتقال أنا مش لاقي حاجة أقولها غير إني أشكر حضرتك يعني باسم المصريين، باسم كل الدكاترة، باسم كل الأطفال. أنا أستاذ في جامعة بنها، وزعلان قوي من نفسي إن أنا مش included في الموضوع ده وأفاجأ بيه النهاردة، لكن أنا يعني على تواصل مستمر وقوي جدا مع الدكتورة إيمان فودة ودكتور ثروت دراز. فان شاء الله I will arrange ان يبقى فيه، هبعت لك نوران جات لك قبل كده برضه يعني to initiate a clinic or a unit of cystic fibrosis in Benha University. It's Benha, not Banha.
Really? I thought it's Benha.
Yes, Benha.
Oh,
BENAHA. Okay. So thank you very much again.
Okay.
And I have the pleasure to introduce my dear colleague